Well, thank you very much for the invitation, and I was so happy to see all the questions coming about alopecia areata management and the use of JAK inhibitors. It was a great segue to this presentation where we'll be talking about the long-term outcome in alopecia areata management. I'm Melinda Gooderham, as you heard, from Canada. Delighted to be here in the nice warm weather. I know you guys think it's cold, but this is what my summer is, and it's amazing. Here are my disclosures, based on the research that I do, and of course this meeting is sponsored by Lilly. So the learning objectives of this session: number one, to just highlight and understand the impact that alopecia areata has on the patient. This one? This one? I just want to stand over here. This one? All right. So we're also going to look at the guidelines that have recently been published and the role of JAK signaling in the pathogenesis of alopecia areata, and then look at key efficacy data where I'll use some of my patients as teaching examples and what I've learned about managing alopecia areata. So first of all, that quality of life impact. You know, I can tell by the questions from the last session, you know, you have patients there, they're significantly impacted, asking for treatments. We're trying to help them with the new therapies we have available. And this recent impact on the quality of life survey was done on almost 800 patients that showed 86% of patients had a severe impact on their DLQI. So that's really the vast majority of patients who are significantly impacted. And if you look, dig a bit deeper on what the issues are, you can see on this daily impact score, about half of patients have a huge impact and another quarter of patients have a large impact. So basically 75% of these patients are affected daily with their mental health and their mood, their ability to concentrate, how they sleep, their physical activity, their ability to exercise, and it affects their identity, whether that be cultural, personal, or religious identity when they lose either scalp or facial hair. And we know this is an immune-mediated condition, and if we focus in on the key players, you'll see that interferon gamma and interleukin-15 are key. We have interferon gamma being produced by the cytotoxic T cell. It's speaking to the epithelium, which is then producing interleukin-15. And you have this back and forth inflammatory dialogue that we now understand better because of JAK inhibitors for other diseases, okay? So when we had JAK inhibitors used for hematologic indications or rheumatologic indications, we saw patients' hair growing back, and that led us down the path to learn more about the pathophysiology of this condition. So bring in now a drug like baricitinib, which is a JAK1 and 2 inhibitor, and you can see where it blocks that interferon receptor in the epithelial cell, but also the interleukin-15 receptor on the CD8 positive cytotoxic T cell. So we're able to block that crosstalk, that inflammatory crosstalk between those two cells, and block that cycle of inflammation, which is leading to immune-mediated hair follicle destruction. So baricitinib, which you might also know as Olumiant, has been around for a while. Of course, it was first approved for rheumatoid arthritis in 2016. So we have almost a decade of commercial exposure, but many years of research even before that approval in 2016. It's approved also for moderate to severe atopic dermatitis in patients as young as 2 years old. So we don't have many other systemic treatments for our patients that are approved down to age 2. So I think this really speaks volumes about the safety data that we have for this medication for regulatory authorities around the world to approve it down to age 2. It also comes in the 2 different doses, 2 and 4 milligrams, and as I mentioned, the long-term data with an established safety profile. So the European guidelines that I was mentioning that came out last year talking about, non-acute, those patients who are presenting with after a few weeks of shedding, which is most of our patients, where first-line therapy would be a JAK inhibitor, and for that we have indicated baricitinib and ritlecitinib, baricitinib for adults and ritlecitinib for adolescents and adults. Second line, third line, and fourth line therapy would be those more conventional immune-suppressing systemic agents that have broader immune suppression, many of which are not suitable for long-term use, such as cyclosporin and azathioprine, whereas JAK inhibitors would be more suited for that type of use. So I wanted to share some case studies from my clinic. Now, in keeping with our AI-generated video at the beginning, I've had some AI-generated images of my patients and what their hair would look like or will look like on therapy. So the first patient of mine is a 43, mid-40s female who has actually an atopic history with allergic rhinitis, asthma. In addition to her alopecia areata, she also suffers from some back pain from a herniated disc. She's on typical medications. And when she first presented to me, her SALT score was 95. Her eyebrows and her eyelashes were mostly affected. She had a few sparse hairs on both. And her current episode had been ongoing for about 5 years, although as a child she'd had previous episodes which had resolved, but then recurred more recently in her 30s. So here's what she looked like at baseline. You can see the wig imprint from the elastic around her forehead holding on her wig. And she'd used a number of topical therapies, topical corticosteroids, intralesional steroids multiple times, as well as topical minoxidil without benefit. And so when she presented, we discussed, what are the new options? And at that point, I reviewed with her Olumiant as well as ritlecitinib or Litfulo as the options. And I was an investigator for both of those medications, so I'm able to sort of say, I've had patients on these medications for some time now and explain a bit about them and how they work. And when I explained about Olumiant, also having the other indications for atopic dermatitis, rheumatoid arthritis, as well as being approved down to age of 2, she then told me, because she didn't report it on her history, that she actually gets eczema. She didn't have any when I saw her, but she had problems with hand eczema in the past and recurrent eczema here and there. And so she liked the idea that, this one option might actually prevent me from getting that bothersome itchy patches that I often get on and off. So she decided to go with Olumiant for that, killing two birds with one stone effect. And you can see here, so this is her at baseline, but after 6 months on therapy, she reached about a SALT 20 score. There were some patches still on her posterior scalp and the back of her neck that hadn't quite grown in yet. Her eyebrows and her eyelashes were filling in, and after 12 months, she reached about a SALT 10. Again, she still had this persistent patch on the very back of her occiput, but she was quite happy. You note there's no wig band mark across her forehead, so she's feeling comfortable to go out in public with her hair. So what could I expect to tell a patient like this about the long-term impact? So we have some long-term data in responders like my patient, so taking the 100% at week 52 of a SALT 20 or less score, and you can see over the next 2 years, so out to week 152, 9 out of 10 patients on the 4 milligram dose are able to maintain the hair that they've grown. If you look at the 2 milligram dose, you have about 8 out of 10 patients on the 2 milligram dose. So, you can have that discussion with your patient. If they prefer to go on the lower dose, they still have a good chance of maintaining the hair that they've grown in that first year. So the next patient is a younger patient, and for her age, I put a range because that's how long I've been her dermatologist. She came to me back in 2008 when she was 15 years old, just after I started practicing. And I've been seeing her for the last 17 years, and I can't believe that I'm that old, but I am. And when she first came to see me, it wasn't just for alopecia areata. She actually also had plaque psoriasis very clearly, which is interesting to me because the last patient with alopecia areata had more of a Th2 skew with her asthma and her atopic dermatitis or her patchy eczema, whereas this patient clearly had plaque psoriasis along with her alopecia areata, which I find very interesting from an immunologic standpoint. I put a SALT score of 85, although it has varied so much over the 17 years that I've been managing this patient. But I would say at the maximum, it was a SALT 85. So back in 2008, because of her psoriasis and her alopecia and her young age, we started her on phototherapy for the psoriasis, and we started intralesional Kenalog injections for her scalp. And even going back, just preparing this slide, I can't believe how many injections we gave this young woman over the years once I saw it listed out and scrolling page after page of notes. We did that from 2008 up to 2011, and we kind of kept patchy hair growth here and there. But in 2011, she was moving away to university, so I transferred her care to a dermatologist in Ottawa, where they continued on with that treatment for another 4 years throughout her university, and then she moved back home in 2015 when I resumed her care. At that point, we knew, we can't do this forever with the injections. She didn't want to keep having injections in her scalp anyway, and so we talked about methotrexate as a way of, one, managing her psoriasis, but also there had been reports of some patients with alopecia areata responding. So I had her on methotrexate up to 20 milligrams a week for another 4 years. She never fully regrew her hair. And then at the end of 2019, her hair started falling out even more. So I switched her to cyclosporin to try to capture some of that, to stop that hair loss further, and as well treat her psoriasis. But we knew that wasn't a long-term solution. So at that point, we went with off-label tofacitinib in 2020, which was working for both her psoriasis and her hair, but then Health Canada came out with the warning after the tofacitinib warning trial was published and the warning came out. And so her next-door neighbor called her up, her aunt called her up because they knew she was taking this medication. And so, of course, she got worried. Everyone was telling her about this warning. So she called the office and said, I don't want to take this medication anymore. I will just live with I'll give up on my hair. I just want you to treat my psoriasis because I'll just wear a wig. I can't hide my psoriasis, but I can hide my scalp, which was kind of sad, but we understood. And so we switched her to a biologic for her skin, which did well. It cleared her skin, but all her hair fell out. She went to a SALT 100, had to start her wig again. Over the next year, as new therapies came out, she started seeing social media posts and asked if she could talk about some of the other drugs that other people were posting their photos on. And so I brought her in and again had the same discussion. We didn't have ritlecitinib available yet in Canada, and Olumiant at that time, we just had the 2 milligram dose. So we were able to get her on the 2 milligram dose to start. She did have some early response of her eyebrows and eyelashes, which made her quite happy. Even though her hair was patchy, she was still wearing her wig for a while, but she was able to wear mascara and feel like her face could hide the alopecia. So what are the early results for eyebrows and eyelashes, which can be so important? I know someone had a question in the last session about this. At week 16, you'll see, at week 36, thinking of AD here, at week 36, you'll see a third of patients have minimal to no gaps in their eyebrows and their eyelashes with the 4 milligram dose, and that goes up to about 45% by 1 year. And then if you take those responders and follow them out for the next 2 years, you'll see on the 4 milligram dose, 8 out of 10 patients will maintain those eyebrows and eyelashes in the long term. And you'll even get an improvement over time. 2/3 of patients, up to 3/4 of patients on the 2 milligram dose. So again, if you have that patient who prefers a lower dose, there's still a good chance that they will maintain that benefit over time. So in the last minute, I just wanted to highlight that Olumiant does have the 5 indications, so 3 different diseases. We have moderate to severe rheumatoid arthritis since 2016, if some patients might feel comforted with that long-term safety data and long-term use. We also have moderate to severe atopic dermatitis in adults, as well as severe alopecia areata in adults. And then, as I mentioned, the 2 years and above for juvenile arthritis and moderate to severe atopic dermatitis, which again, some patients are reassured when there's a pediatric indication because they know that the regulatory authorities are much more strict on pediatric approvals than adults. So having that sort of combination of the length of time, the breadth of indication over diseases, the breadth over the age span, that is something to consider when discussing with your patients. So the take-home message is alopecia areata really can have a very significant impact on quality of life. Even if patients aren't telling you that, 86% have a severe impact on their DLQI, with 75% of those patients having daily large or huge impacts on their daily activities. JAK signaling, we've learned, is so important for the perpetuation of the inflammation, and if we can block that signaling, we can reverse the disease. And we know that Olumiant has shown responses that are sustained over time with eyebrows, eyelashes, and scalp hair up to 3 years. And I'm exactly on time. Thank you.
Thank you very much, Dr. Melinda, for this informative talk and the interesting cases. And we can take questions. We have one question.
Thank you, Dr. Melinda, for the lecture. I was just wondering, with regards to your patient who you started on baricitinib 2 milligrams, did you start it along with the biologics, and do you support putting JAK inhibitors along with biologics in terms of those patients?
She actually stopped the biologic when we made the switch. So yeah, I didn't put that little detail in, but it was like one or the other. So we switched her over. I actually did, back in the day, a study for baricitinib in psoriasis at higher doses, and it does work for psoriasis at the higher dose, but same with tofacitinib, it didn't go forward for skin psoriasis. But I knew from my own experience that it would also help her psoriasis, so she doesn't take the biologic anymore. But it's a good question. If, let's just say, she needed the biologic, I wouldn't worry about an interleukin-23 inhibitor combined with a JAK inhibitor. TNF, I would not combine. But for 17 and 23 inhibitors, I personally, it's off-label, would not be concerned if I needed, for whatever reason, to combine them.
Excellent. And what higher doses were you talking about in terms of Barry?
For baricitinib, I think the doses, I'd have to pull the pair, I think it was like 2, 4, 6, 8 or something like that. Like it went up to 8 or 10 milligrams was the highest dose that was being used.
Okay, thanks
but
so much.
I had patients clear on baricitinib for their psoriasis in that study, and this one guy kept asking me, when's that drug going to be approved? That was the only thing that ever worked for my psoriasis. When am I going to be able to get it?
And just to emphasize that baricitinib is only approved for alopecia areata and atopic dermatitis, not psoriasis. Okay, I have a question for you, Dr. Melinda. The cases that you actually presented were very interesting, especially given the comorbidities. Now, since we have lots of JAK inhibitors, when it comes to selecting the JAK inhibitor, when would you choose baricitinib?
Well, I'm kind of in a shared decision way. Like I let the patient know what all of them are, because for some patients, the length of time on the market, the wide range of indications, some patients like that about a JAK inhibitor compared to another that might only have one in so many patients. So some patients come in asking for a certain JAK inhibitor because they saw it on a post and they saw someone do better or do report benefit on a certain JAK, and we'll talk about that. But when I'm sort of providing all the options, I sort of explain them all, and then I let the patient tell me what's important to them.
And in your practice, usually, if a patient starts on a JAK inhibitor, how long do you keep them on it until you label the patient as a non-responder?
I would do, first of all, at least 6 months, see if there's anything. But if I'm getting some movement in 6 months, like let's say they've got their eyelashes and eyebrows and maybe their SALT 50, then I would say, let's give it at least another 3 months before we switch, because if you start switching, and patients are also reluctant to switch because what if you then lose what you've gained? Probably the max I would go is 1 year, but 6 months I would, of course, make a critical decision, give it to 9 months, but at 1 year I would call it quits if I'm not happy with that.
My last question to you, how often do you actually experience dyslipidemia with patients on baricitinib? Do you experience that often? If you experience patients who have altered lipid function once you start the medication.
Altered immune function?
Lipid function. Lipid, if the lipids actually becomes altered and they become raised and elevated.
Well,
do you experience that often?
You know what, that happens with all JAK inhibitors. You just see a general elevation of the lipids. So if it's balanced with like LDL and HDL, I'm not too concerned unless it gets into concerning levels. My husband's a cardiologist, so when I'm reviewing my labs, I'm like, hey, what do you think of this? And he's like, nah, not a problem. You know, we see something change and we get worried, and you know, those are minimal levels to what he sees in his practice. So I kind of review it with my local cardiologist.
Okay. Any more questions?
Yeah.
Dr. Siri Kumar.
As usual, a great presentation. One of the issues that we face is that the so-called severity scales in alopecia areata are highly deficient. I see sort of a lot of patients with less than SALT 50 involvement of the scalp who have severe alopecia areata in the beard and the rest of the body. So why should SALT 50 be considered as the gold standard for a JAK inhibitor? Why not somebody with a full body hair loss or a severe hair loss in the beard? You are only talking about the eyebrows and eyelashes. What about the beard? What about the mustache? What about the arms, chest, body? So we do seem to have a lot of deficiencies in the severity scaling. This is one observation. The second is, yes, with Olumiant, we have the advantage of the 2 and 4 mg. But like the previous question, how long do we continue a patient on a medication before we consider switching? Because in some patients, it's quite challenging. And we don't see a response which is uniform. For example, you may see a mustache or an eyebrow growing, but then nothing is happening in the scalp. So in a situation like that, suppose you have a 2-point scale improvement in the eyebrow and eyelash and mustache growing, but nothing is happening in the scalp. What shall we do?
So for your first comment about the SALT 50, which I agree with you is just an arbitrary number that has no meaning on the patient's impact. Unfortunately, regulatory agencies will choose those numbers, and that's not what we agree with. And the same thing happens with psoriasis and atopic dermatitis, where we then try to bend those recommendations for high-impact sites. So hopefully this will happen for alopecia areata over time. For that patient who's not responding in other places, a lot of my problems have been over the past years is my patients have been in clinical trials and we're not allowed to use other therapies. They're only on monotherapy. There is some good data about patients who haven't responded in the first 6 months that you do have late responders, so there's that reassuring bit. But what we're still lacking information on is combination therapy. So now that I'm using them as commercial drugs and not investigational drugs, I'm able to add in oral minoxidil. I think they were just talking about it in the last session. I have not gone up to 10 milligrams. I usually go up to 2.5, but I'll start at 1.25 milligrams of oral minoxidil and bump it up to 2.5 after a couple of months. And also we can do some intralesional injections and sort of combine all the therapies. But if you're getting nothing except an eyebrow after 6 months, you know, that's a discussion with the patient if they want to switch or if you want to try to optimize or continue on. The problem is we don't have a lot of options to switch to at this point. So I would really, it's that squeezing the lemon, get as much out of each lemon as you can until we have more treatment options available.
Higher dose in psoriasis, for example. So more than 4 mg, we don't go up, isn't it, for alopecia areata?
Well, it would be off-label, and accessing it would be harder to go. I was just mentioning about other publicly available studies that would be off-label, and I don't want to get in trouble. So,
I have one question for you, Dr. Melinda. If you find a quantiferon positive during the screening before starting the Olumiant, how long you will wait until you started, once the patient started on the anti-TB treatment?
I typically, just from my psoriasis days, I would wait 2 weeks. I know it varies by region what the typical is, but for a lot of the clinical trials that I do, it's typically 2 weeks, so that's my comfort zone. But I would go with sort of local practice on how long you treat before starting an immune modulating agent. But most clinical trials have done 2 weeks.
Okay. I believe with that, thank you very much, Dr. Melinda.
Thank you so much.
Thanks. We're not going to be having a coffee break. We're just going to be moving to the next session. Thank you all.